Good afternoon, everybody. Thursday, April 13th, Board of Directors meeting for the Kern River Valley Healthcare District. Call the meeting to order at exactly 3 p.m. We'll start off with the flag salute with Director Blythe and invocation by Mr. Gordon.
Please place your right hand over your heart and repeat after me. I pledge allegiance to the flag of the United States
of America,
to the republic
for which it stands, one nation, under God, indivisible, with liberty and justice for all.
And for those of you who would join me, Heavenly Father, we're just, as we mourn the losses of close friends, family members, and just remember that we ask that you be with us in the troublesome times. Father, as we make decisions for the healthcare district, please influence those decisions that they would benefit the community and all of the employees of the healthcare district at large. Father, I just ask these things in Jesus' name. Amen.
Yes.
Yeah.
Amen.
Thank you. Our mission statement is on the agenda for all to read. Public comment is reserved for persons who address the board on any matter under our jurisdiction. But, do we have anyone from the member, or forgive me, from the public who'd like to speak at this time? No? Okay. Move on to consent agenda. The following items are considered routine, non-controversial by hospital staff. All items will be approved in a single action unless one of the board members or public wishes for it to be removed, and we can discuss it at a later time. We get a motion.
On the consent agenda,
Yes.
is that the last Heidi, you were gonna change to where some stuff was changed on our meeting for
board PMP, those will come back to the board PMP committee before they come back here. So we haven't had another committee meeting.
So it's been removed at this point.
They'll
yeah,
be
there was
revised-
another committee
they'll
meeting, she
be
ran it.
revised and approved at the next board.
Okay.
Yeah, that was the board PMP, and we haven't had a board meeting since, another meeting since that.
Okay, then do you need a motion?
Make a motion to
Make a
accept.
motion to accept that.
Can you have a second? Second. We all in favor? Aye. Aye. All right. Okay. All right. Let's go to reports. Ms. Hess, are you here?
I'm here. Can you guys hear me okay?
Yes, ma'am.
Okay, for the foundation, we have our heart walk on Saturday morning. So we're going to start it at 9 o'clock. Whiskey Flat Mayor's going to be there. Joe Brennan's coming from Supervisor Peters' office. I think we're going to have an okay turnout. It happens to be opening day for Little League too. So we're going to lose some of the families. But overall, we're looking for good weather, and we think it's going to be a great event. Moving on to the auxiliary, I have really good news for you there. As you know, the month of February, we were pretty much closed. We were closed due to some remodeling, and then we had folks out that were sick, so we didn't have enough volunteers. But they more than enough made up for it in the month of March. The auxiliary brought in $15,000.
Wow, that's awesome. Nice.
Yeah. So that's my report, unless anyone's got any questions.
Any questions from Ms. Deb?
No, thank you, Deb.
No. Thank you, Debbie.
Thank you.
Sorry, who's going to give the report from Mr. Fenstead?
I have a prepared statement for the medical staff report.
Okay.
I will read that for you. Pharmacy and Therapeutics Committee met on March 8th, discussed COVID-19 preparations under old business. We reviewed a couple of policies. The committee discussed order entry options in T system, as well as standardization of diluent bag type and volume. Topics forwarded to ED committee and will remain on the agenda. Committee also reviewed regular reports from CAPS, MERP, medication shortages and EOC rounds in the pharmacy. The Medical Executive Committee met on March 21st. The committee reviewed and approved 4 credential files. Committee reviewed and approved 1 policy with changes. The committee reviewed formulary requests regarding interlipids, which was approved. They also looked at an accompanying draft policy, which will go to P&T to begin the review approval process. The SNF CQI continuous quality improvement meeting met on March 22nd. The committee reviewed and approved 2 policies. The committee reviewed and approved for retirement 2 policies that no longer in practice. And then the regular reports were reviewed. The antibiotic stewardship committee component of the meeting was held directly after the CQI meeting. Committee reviewed the 4th quarter antibiogram. The surgery committee met on March 23rd. A lot of committees in March. Committee reviewed and approved 1 policy and reviewed a draft policy. The committee also reviewed and revised the general surgery core privileges list. They also reviewed their regular surgery site infection report. Med Quality Council met on March 28th. Committee reviewed CDPH plan of correction report for pharmacy. The requirements have been met for 6 months, can remove from regular reporting. Outliers will still be reported on. The committee reviewed CDPH plan of correction for a report for acute care. Committee reviewed and approved the quality assurance performance improvement plan for 2023. Board members were given updates on regular reports, and that is the end of the report unless there are questions.
Questions, sir?
Mark, we talked, I think, I don't know if this is part of it, but the hand washing can be so damaging to your hands over a period of time.
Yeah.
And it's so much. And you talked about looking into maybe an alternative.
So we're always looking for alternatives to the soaps and the alcohol-based cleansing, disinfection station that we have. There just is nothing out there that we can find. We have since replaced the alcohol-based ABHRs, which are the alcohol-based hand sanitizers that are like that one, that blue one on the wall right there. We have a different product that has a gel base to it now, so it's a little less caustic to the hands. But I still have nurses who are very sensitive to it, so they do their best. They're not so sensitive to the soap at the sink and those stations, so they try to limit their use of the alcohol-based cleanser with the disinfectant other ones. So I mean, we're doing the best we can with what we have, and we're always on the lookout for new products.
Even if it costs more, right?
Absolutely, yeah.
Okay.
We're not gonna skimp on that. These nurses have to be here every day.
Yeah,
They have to
it's
wash
sterile.
their hands
Terrible.
hundreds of times a day, and it just takes the natural oils out of your hands.
Does it have to be alcohol based?
Yes, according to CDPH and the CDC, it has to be alcohol based. As far as these HBARs, and it has to be a certain percentage of alcohol. I think it's over 60 something percent. Greg, you know, 63% or something.
Yeah.
So it's it's hard on their hands. It really
So the
is.
ones, the sanitizers and the hand washes that are with essential oils doesn't work.
They're not approved for use yet that I've seen. And we are constantly in our products committee evaluating new products. Alex is always looking for a new product. The nurses are always looking for their own new products, like, is this okay? You know, they'll bring their own stuff.
That's all we use at my house is the essential oil base.
I'd like to see it, just
And it comes with, either the foaming one and different ones, so.
like method or something.
No, it's actually through doTERRA and it's all.
I'd like to see it, just
all
to see if
regular
we can,
bottle.
yeah.
It's there.
Again, we're always looking for, something to help the
You think
nurses.
that's gotta be toxic after all?
Because it's hundreds of
Yeah,
hand washes. I mean, a
Well,
lot of hand
that's
washes per day.
Not healthy. I mean,
Every time you go
washes-
into the room and every time you leave the room.
Right.
Every time you put on gloves, you have to wash them before you put them on and after you take the gloves off. I mean, it's just,
Yeah,
and so with those kind of requirements, it's stands to reason people's hands are gonna break down.
Absolutely.
And frankly, in my opinion, humble as it is, I think that because of our hospital acquired infection rate being so low, I think what we do works.
Mhm.
So, you know, you can't really, if I had a problem with cross contamination, I would be more willing to be much more diligent or almost, Nazism, like you didn't wash your hands when you came out of the room. But I don't see, you gotta practically apply those kind of things. And Alex does a good job with the hand hygiene surveillance that we do. So.
all their hands are getting so skinny from washing them, and pretty soon they might disappear.
It might disappear all the way.
So that wouldn't.
There are some nurses who actually wash their hands so much they don't have a fingerprint
Yeah.
left
Yeah.
to be able to access the Pyxis medication station because it's a fingerprint.
There's got to be an answer. So we're not the only ones talking about it. So.
So anyway, those are my comments there.
Any other questions? No. Right. Thank you. Replacement for Dr. Finstead.
Okay,
Are you giving Tim's report?
I am.
Hi, Tim.
So Tim did call a little while ago to have me discuss some bullet points. A few of those bullet points I'm going to let Dave touch on during his report regarding some of the current health systems supplemental payments that we've had, the ERC payments that have come in and things like that. So Dave, you can talk about that when it's your time. I'm not giving Dave's report. I also wanted to introduce, we have a new HR manager. She's been here and she's hit the ground running. I think she's going to be very good for us. She actually requested a meeting with the surveyors that were here yesterday, so she could get a feel for, kind of what the roles and responsibilities from a healthcare perspective. So she wanted to get their input. They didn't call for her, did they? I think she called to get an appointment with them to meet with them. So I think she's going to be very good for us.
Are we under survey again?
We had our revisit the other day,
Okay.
which started Monday.
Okay.
Not going to get into that too much. There were some things that they found that we have to address. But I think all in all, they were pretty pleased with the implementation of our plan of correction. For the most part, there are things that are going to come out that we have to address, audit tools and things like that, these paperwork audits that they want to see. So those kind of things we got to tighten up on, just pull our belt together and make sure we're doing them. So
Is our current girl going to leave early or?
Sarah,
Yeah.
she's gone. She left April.
She is. leaving.
Yeah, she is in North Dakota, as far as I know.
What's the name of our new manager?
Cassandra Coleman. She does have an extensive HR background, but not in healthcare. Is that right? So, hey, Scott, have you spoken with her? Has she reached out to you at all?
Not yet.
Okay. So we did encourage that line of communication, and I gave her your personal contact information.
Yep.
Okay.
Yeah, certainly before any disciplinary action occurs.
Sure. Okay. Fair enough. And the other thing is, the last thing on here is Dr. Hall, a new ER doctor that started about 3 weeks ago, is phenomenal. We found him through a locum tenens group, but he wants to come on full time and he wants to pay half of the buyout because there's a fee to pay out. Like this locum tenens group charges 30 grand to get out of the locums contract. So Dr. Hall's willing to pay half of that.
Cool.
So good. Yeah, he lives in San Diego, I think, and he was working in Texas, but he's coming here now. So anyway, he likes our little community hospital. But there you go. That's the CEO report.
When did they start?
He's already been here.
Oh.
He's working for us actively right now.
That's excellent. Any questions for Mark regarding?
Or which doctor is he replacing a doctor?
So Dr. Newell is kind of, I don't know if he's semi-retiring. I know he's taken about 6 months off and
Going on walkabout.
he says he's coming back, but we don't know. So he was very, very good, did a lot of shifts for us. And I think Dr. Hall will fill in that need thing nicely. Yeah.
Any other questions?
I don't know.
Mr. Gordon?
Heidi's going to give my report. Okay. Anybody got a drink of water? No, I'm kidding. So our COVID positivity rate is less than 1%. It's about 0.45% right now through the ER. We've had one positive case out of 180 plus visits. So
Is it different variances or?
There are
when you say
variants.
COVID, so I mean,
It's all one blanket. So if I get a positive COVID, doesn't matter what variant it is.
it'd be a bad
It's a-
cold and it's still considered.
I don't call that.
Sort of, oh, okay, okay.
If they test positive on a study for COVID, they get counted in this
Okay,
statistic. And I do have those statistics. I've been keeping them for about 2.5 years now. It's a very, but it's simple now. I've got it down to such a easy task. I go in the morning, count how many there were and how many, anyway, very easy. So the masking and vaccination mandates have been lifted. I also saw a thing today put out by that was saying that the monovalent Moderna and Pfizer vaccines are no longer approved for use. Did you see that, Greg?
Yeah, that was expected.
Yeah.
We've been planning on changing the primary vaccine, like if someone wants to have a new vaccination for COVID, they wouldn't use the red top of the
Right.
Moderna, which is what we use. They would just use we'll use the bivalent.
The bivalent one.
They haven't released the rules about that,
Okay.
nor have they released information about a second booster of the bivalent recommendation. So we've
Okay.
got a few people, there must be some news organization that's reporting something because we've been getting we've had a few phone calls of people saying that I'm supposed to get another booster, but that information is not out yet. At least it's not on the CDC website.
Okay. Thank you. All righty then. So the transportation service has taken a bit of a hit related to road closures and weather conditions. But I think that we have received our final reimbursement for the month of March. I did submit it to them. Now we're going to have to meet with Dave and Tim and a few others to decide and develop ways to get a reimbursement for that service. So we'll be actively seeking those recommendations pretty soon.
You get the phone numbers for that, right?
CNA class is scheduled to begin April 17th. We currently we're going through the orientation process with 11 students who have applied. Hopefully the attrition rate is higher than it has been in the past. It's been difficult kind of making the transition to the amount of students that start the program and then the ones that actually graduate and then come to work for us. It's not as good as I'd hoped, but we're still working there. We have a new instructor, Ben Torres. He's going to be really good for us. So he's excited to do it. He's got fresh perspective and I think he's really going to be good at it. Surgeries are coming back again. Dr. Buxton has done 5 or 6 in the past month and has 2 scheduled for tomorrow. This is a good thing. So we're happy to see that. Assembly Bill number 40, I did mention that at the board PNP meeting, talking about patient offload times. I know that that's something that might be be near and dear to Ross's heart. He's been dealing with that from before when he was a working person. But this assemblyman wants patient offload times to be 20 minutes or less 90% of the time, which good luck with that. But we'll see how that goes. Right, Bob?
Maybe here, but not.
We can do it here. We don't have an offload time problem here.
Yeah.
Typically,
a little bit struggle with that.
the trouble with our patient offload times is always caused by Bakersfield hospitals because we can't transfer patients out. So they occupy our beds here and we can't get them out of there. So that's our biggest problem. So. And
It's about time that the state has done something on that. It just isn't a priority for those hospitals to do something about it,
right,
and maybe this will turn the corner on it.
yeah. Well, I don't know. And I've heard stories about bed capacity for the amount of people we have in the Bakersfield area. It's very unbalanced.
Yeah.
You don't have enough beds to take care of 300 or 400,000 people. And so anyway, those are all bigger problems than what we have. So,
It's like Kaiser. I was at a meeting, oh, this has been 10 years ago, but it's their attitude. Their attitude was, one of the guys asked, why don't you have a hospital here? He says, we're too profitable. We're making too much money to build a hospital.
yeah,
So, that's,
they have the wrong objectives in there.
yeah, it's all about money. It's not about taking care of patients.
And we already spoke about the plan of correction revisit. They exited yesterday. There were a few things. They were happy with a lot of the things that we've already implemented, but they were not happy with some of the audits that we're doing. So we need to tweak those, and there will be a revisit after that. So anyway, yeah. So there you go. They did send the same surveyor that I wrote a letter about, and I'm going to have Tim review the letter before I submit it to them. But we'll see how that goes.
Mark, on transportation, how close are we to getting approved with Aetna, Wellcare, Anthem?
So we haven't actually, I haven't approached them. My thought was we could charge each individual a cash amount, and then they could submit the application to their respective insurance companies for reimbursement. And that way it keeps us out of the application process. If that's not how we want to go, I'm open to suggestion. The one for Current Health Systems was so, I don't know, it had to be 30 pages long, this application. And then Barbara was concerned that if I made this application out, it might affect our reimbursement for other things. So
The reason I'm asking, I had a client in my office yesterday who was with Anthem. Their transportation person came in from Lancaster, took them to 2 stops in Bakersfield, then to the farm, then back home, and it returns to Lancaster. So there's got to be some funds in there that
right,
we're missing.
that's true.
That's my concern.
Okay.
What if we try to contract with the person in Lancaster that's sending the ambulance, the transportation people there? What if we were a sub for them?
They're all good, great ideas. And I think that,
I can get you the number to all 3 of them if you want.
yeah, why don't you do that? I was
Is somebody,
gonna have to switch hats.
right, is somebody gonna maybe help the patients fill out those applications? Because if,
Yes,
okay, because
Yeah.
otherwise they're.
the one for
not gonna do it.
Current Health Systems is easy.
Okay,
And the application for us to get reimbursed, like bill for it, is much more difficult.
okay,
But for a person, like yesterday, I had occasion, I was going to use the transportation service for my wife to go down there because I was dealing with the survey up here. I'm glad I didn't do that, but she had a procedure down in Bakersfield. I was going to just take advantage of the service. But anyway, she had a episode coming back up to Canyon. I was glad that I was able to pull off and take care of that situation. So, but be that as it may, I would have paid for that service, that resource that
And just to give you an idea,
but anyway, yeah,
Aetna contracts with Safe Ride.
okay,
Anthem contracts with American Logistics. clearly, if there's funds that we can capture,
Right.
why not at least try?
I don't know how many lives are up here that might take advantage of it, but certainly,
A lot.
so that would be a good,
We could be a hub for them because they don't want nothing to do with us. You know, I mean, we're out here in the middle of nowhere.
and I could actually have KJ, my main driver, reach out to these places and see what those applications would look like and how difficult they'd be.
I'll get all the numbers to you.
Now, I know that Ridgecrest Medical Transport also must be contracting with those places as well.
Sure they are.
Because they come through here all the time.
Yeah,
I saw one, I saw them on the road down to Bakersfield, you know,
Yeah.
so. We could be getting some of that,
Question for Mark
Sure.
is over.
Go ahead, please.
Do we have the medications that we need to treat people that have tested positive for COVID?
yes,
So we
we have Paxlovid and we have Remdesivir, yes.
so they're available?
Do they go out of date quick or?
No, I don't think so. They have shelf life that's just. They don't go out of date. no.
Good.
The vaccines have to be maintained at controlled room or controlled temperatures. And then once is it still that if you open them, they have to be used
12 hours.
within 12 hours? Yeah, so. As a matter of fact, taking them out of the freezer. or whatever. So.
Thanks.
Hey, Mark, before we get off the subject, I have some philosophical opinions on this. I'm really in favor of us expanding this program and making it available to
Which
more,
one?
the transport. You know, and my point is, even if we're not completely successful initially at getting these fees paid either by the patient or the insurance company, that it's still a financial benefit to the hospital because we get more business. And it also, I think, fits very well into the being community oriented and really having, giving them the community residents better access. So even if it's a $20,000-$30,000 line item in the budget that doesn't result in any direct reimbursement, it's probably something worth considering.
Well, and I'm sure with what Director Parks can expand on this, the number of individuals we have in this valley. Just that you write alone would keep your guys busy.
Absolutely.
Yeah.
And, you know,
Have 8 to 12 visits per year.
Right, okay.
It's free to them.
It's free to them.
And
It'd be really good for us to look into that then. for sure.
And it wouldn't take too many admissions to the hospital to help pay for it.
Absolutely.
In the goodwill of everybody seeing us doing the right thing.
Correct.
You're right, Dave.
And probably not very many admissions to the SNP either.
Exactly.
I put that out there.
You never know how those things translate. Now, the one missing piece we're not talking about is the individual's physician, and I don't know how important they are to whether or not the patient will can receive services with us. It shouldn't matter, but
Well, I think we would all be surprised of how many people still don't know about the service.
That's correct.
I mean, even though it's getting out and some people know it, some people may have known it today, but they don't remember it tomorrow when they need it.
We need that marketing piece.
Yeah,
Yeah, so.
yeah.
That's
And
correct.
I think Jeremy, I've asked Jeremy to continue to make rounds around the community and just put those flyers out and make sure, you know, we're even taking folks across the lake to Woodford Heights to that clinic.
Oh,
So
that.
to them, to our,
Where's that other one?
to that clinic.
It's at 67 East Evans Road.
Did you
To
get,
the wonderful,
do you have an x-ray machine?
We just don't
You
have a
used
tech,
to use ours.
and they have,
Could our tech go over and use yours?
well, I don't care, but I'm fine. I'm going to need to talk to.
Well, no, I mean, if we really needed an x-ray.
Yeah, yeah, because we send us ours over here,
Right, so.
but yeah, we have one. We just don't have a radiology person.
so I have one more piece of information from
Yes.
the CEO report that needs to be, I just heard from our CEO. This morning, he stooped over to look at his tray. He was printing off his board packet and his hip popped out of place. He was taken to the ER just a few hour, maybe two ago. And he just texted me and said the reduction didn't work. Dr. Saeed is coming in and taking him back to surgery. So that's where he's at, and he probably won't be back on Monday. So I asked him if it was okay to tell you folks that, and said yes. Please.
Thank you.
There's the update on our CEO.
Can I add something?
Nope.
Maybe.
It has to do with transportation.
Hey,
I just want to let you guys know that the Senior Inc., they've been putting it in their newsletter, and I just dropped off flyers that they're going to put those in the Meals of Wheels, those luncheons that go out to those people that are home with no transportation. So we are getting more word out there.
Thank you.
we're doing about 10 a day. I mean, we're doing about 10 transports a day, and it's still, there's only 2 of those guys. So they can't, if there were more to do, I don't think they could do them all right now. So.
That's okay. I prefer to have too much and not enough.
So there you
Good deal.
Questions?
Question.
No, I just had a question about whether we should be discussing.
If he told me to tell you guys,
Okay,
that's
then
why
say that. That's all I need to
Yes.
say, that was okay.
I asked him before I even said anything. I said, should I tell these folks here? And he said, yes, please.
Okay. Want to make.
I understand. Yeah, John.
Well, I'm happy to hear.
I was making sure before I said anything.
Well, I'm happy to hear that surgeries are coming back.
Yeah.
Is there any input on med surg? I know that's always been a concern. Any idea or probably not the one to ask or?
What do you mean as
Well,
far as
I just-
what's concerned?
I just remember, when Chet was here, like when we go through the product line analysis, like you'd always say, med surg is always, not performing. So I don't know if that was still a concern.
It is still a concern. However, I don't know. We've had consultant after consultant come in to look at how we manage staffing in there. And with the fact that I have Title 22 mandates that I have to maintain a certain number of staff per patient day, the load is what it is. Once I get to the minimum staffing level and I add another patient, I have to now go over that again, that threshold. So I'm always going to be overstaffed, what it looks like on paper.
Okay.
It's always going to be that way. Chad and I used to go around and around about that. And so we flex when we can. And unfortunately, I'm not going to be sitting in front of a surveyor someday in the case where a patient falls and they'll say, why are you understaffed? Because my CFO told me to send staff home. That's not going to happen when I'm in this chair. So Chet and I had that discussion several times, and he finally relented and stopped teasing me about it in the product line analysis. So for the most part, I have a patient acuity classification system that we use to manage how many patients are the level of care that's required by each patient on the floor. And we try to meet those staffing requirements. And I think.
Yeah, the current year, med surge year to date financial picture, they've actually, their overall staffing in terms of dollars have been reduced because they're using registry contract labor less than they had in prior years. So they have improved the bottom line by using a higher percentage of in-house staff.
I also developed a tool that I manage my staffing based on my acuities. And I count, contrary to what Chet used to report about 2.5 staff members overstaffed, I was averaging about half an FTE over every day. And if I can manage it to that level and I can prove the numbers, And that's when he basically got off my back about the 2.5 over.
And is the census, is that based on whose heads in the bed at midnight? Or
It is
at a
based
certain time?
on
Admission
shift by
time?
shift,
Shift by shift.
7 AM to 7 PM.
Okay,
Mine is, his was based on midnight to midnight.
Right.
And he used a different acuity level. He used the physician acuity levels
oh,
to manage his numbers, which is definitely different than what I was using to manage mine. I need to know the nursing numbers. He used not necessarily a DRG code, but he used the level of care that each person got billed for. Does that make sense?
in ER.
No, we're talking on.
Okay, I was thinking that from ER that was admitted, I was thinking that they're counting all the ER patients, not just the ones that were admitted, so it was just on that.
It was just the acute care patients. And he counted swing beds differently, and he counted observation differently, and frankly, all those patients that are out there require care.
Under the same
So it
nursing.
is what it is.
Yeah.
Anything else?
Any other questions from Mark?
I talked it out.
The scheduling, since we have so few, the doctors, how do you schedule it, you know? If they need to do a procedure here, do you have it all done in 1 week, a month, or?
Are you talking about surgery?
Yes,
So Dr. Buxton will come up on a Friday. He'll do scheduled surgeries that he scheduled from a previous visit. Like last Friday, he'll say, okay, we'll schedule you for next Friday. And then that Friday, after his surgeries are done, he'll see more patients across the street. Is that how it works, Ray? Pretty much?
well,
And
then,
then, so he schedules those for another week or two down the road. And so that's how that,
yeah, so there's advantage
that works.
to use of it, yeah, that's
Yeah.
good.
Dr. Spahn just calls up and says, I want to be there tomorrow. and do surgery. That's how that works.
She's so cool.
Any other questions? Nope. Thank you. Need a gallon of water?
Yeah, I need some.
Okay. Dave? Floor is yours, sir.
Thank you. Before I go into the finance report, Mark mentioned that I was gonna start out with something Tim was gonna present. We got some real significant news this morning. An email came in about 8 o'clock. The program that we submitted last, I believe, September. Now, I really want to give kudos to our CEO because he's the one that first brought it to my attention, this opportunity. It's a federal employee retention credit program. And we had a consultant that we hired. And remember, originally they wanted 20% of the fees, and we got it down to 10%. Well, thankfully, we're going to have to pay those 10% fees because not only did we get the 2.8 million we were hoping for, it ended up being 3.1 million.
Very nice.
And just to let you know, to put it in perspective, this isn't something that every hospital gets. This is, in fact, there's only a handful of hospitals that I'm aware of that has received this funding. So it takes a little bit of luck. We were fortunate enough to have the numbers turn out the way they did, that we qualified because we had one quarter in 2021, which is after COVID, come in 20% less revenue than the same quarter in 2019 before COVID. And that it had to be more than a 20% gap from quarter to quarter in order for us to qualify. And we, in fact, hit those thresholds. And that's what translated into the $3 million. So the email said we're going to be getting the check in 7 to 10 days. And the one thing the board, Tim is looking for input from the board as far as whether or not we need to consider some type of bonus program for the employees for some of that money. And he's open to suggestions before we put something together. Specifically, he'll work with his team here and give you a recommendation in the next couple months. But that's extremely good news. And keep in mind, none of that 3 million is in the budget at all. So that's all goes to the bottom line.
What's the name of the program?
Employee retention credit, yes.
That's
And-
more reason why we should give the employees a good part of it.
Yes, so that's up to the board, obviously, and Tim's open to suggestions as we move forward on it. Obviously, when we actually get the cash, which should be in a week or so, we'll be in a good position to do that.
Could we talk about it next board? We can't do it today.
That's correct. And then let's see what they come back to us with as well.
Oh, okay.
And then we can all talk about it openly. Because I agree with you.
Yeah, yeah.
So Dave, do you want to mention the current health system supplementals that came in?
Yeah, I mean, that's just the normal IGTs are starting to come in. So we've got over half of that $8 million that I've been speaking of every month is now coming in. We've got one more big one from Health Net for another 3 million, and that should pretty much take care of it. So the good news is we'll probably have all our IGT money by the end of this current month in April. We'll probably have 95% of all our IGT money all in, plus the extra $3 million. So later on, we're going to look at some investment performance and how that's also going to translate. That cash coming in will also translate into a much higher interest income that we should expect each month going forward. So obviously the one advantage of Bob having delays in the master project is we're hanging on to that money a little bit longer, and we're benefiting because the interest rates on treasuries are so good right now. But let me go into the financial report.
So one more thing, Dave, how about the state ERC?
Oh, yes. The state ERC check came in last week. Barbara is putting a detailed plan together. And before I forget, now I mentioned Barbara's name, she was also extremely important in the process. The reports that she had to submit for this $3 million program, she spent a lot of time and did it obviously perfectly. So we got it approved. So she really needs to get a lot of credit as well in terms of her participation. Now she's had a lot of those kind of projects this year. So we're also going to talk later on about one agenda item on the board approving the final budget in a couple months. And I'm maybe wanting a couple extra weeks for our budget preparation because we're starting to get behind on a lot of other things. So this has been an extremely busy year in finance, and thankfully it's paying off for us when we see these results like we got this morning with this $3 million. But Barbara played a big role in that. The state detail came in, so we got a detailed list by employee of how much, and then we got a check for this exact amount that adds up to the detail by employee. I think it was like 282,000. So we are instructed by the state of California to submit these checks to the employees for the amounts designated by the state based on their calculations. On average, each full-time employee got $1,500. And keep in mind that $1,500 was a result of you guys agreeing to the $500 bonus in December. Otherwise, that would have been $1,000. So basically, they matched that $500 and gave them an extra $500 for that as well. So, you know, I think we're doing our part in the little pieces that we play to make sure our employees are you know, getting a little something out of all these programs. But that should be coming to each employee late in the next couple of weeks.
Could we add interest on that for being late with it?
Yeah, we'll just send us a check donation and we'll figure it out. Okay, I'll go into my financial report.
And Dave, can I ask a question? When you start your reports, can you start with all the grants and the monies that come in first? Because
Sure, I can
that
do
would just
that.
make it easier if they're all listed, and that way we know each one that came in. And
Yeah,
so
that's a good idea. Certainly,
ask, you know, what about this one? What about this one? We will know right off the bat what came in. That would make it easier for me.
yeah, good idea. I can do that.
Then we'll start deducting it, but let's know what's coming in.
Okay, so we're gonna go to, we're gonna talk about the month of February. It'll be a pretty quick presentation. Just wanted to show you these graphs. Getting closer here, sorry. Here we go. Okay, so we've had an up and down year. Each month, bottom line, the net income, we started out the year pretty positive. You can see the last several months down here, lost money in October and now again in February. We had our second losing month of the year. Volumes are way down. If you look at acute days, we went from 158 down to 84. So besides the disadvantage of having our IGT payments delayed, we also have lower volumes. That combination caused us to have a be below budget on the bottom line. The financial strength index also reduced from 2.41 down to 2.03. So the month itself on the profit loss, looking at page 24, we had a 237,000 net loss compared to the budget of 301. So about 540,000 off budget. And most of that's volume related. If you look at the volumes, 16.86% below budget to 8.3 million compared to 10 million in the budget. A much slower month in February. March picked up a little bit, but it's still below budget. So what we're looking at in general, obviously the big financial news was the CRC payment, because that 3 million goes right to the bottom line. So if you look at our year-to-date picture, we have a bottom line of about $1 million, which is quite a bit below the 2.6 million budgeted. But once we post the ERC money, will probably put us right back or maybe even a little higher than budget for the year. So we're likely to finish the year up better than budget because of that program alone. Put us over the top in terms of bottom line and also in a cash position. We expect to have at least $500,000, if not $1 million more in cash than what we thought we'd finish the year. So those are all also important financial indicators showing financial strength for this year, even though we haven't had the type of success on our patient volumes nor on the IGT payments. We did have the one delay on the IGT that it'll be a couple of months after the end of the fiscal year, where an extra $2 million that we expected before the fiscal year ended will push into next fiscal year. So it's not really a cut in IGT payments, but it's a delay of a couple $1 million, but got more than offset by the $3 million on the ERC payment. So you can see we're real close on the budgeted expenses on line 28, 0.2% off on budget, 20,852,000 compared to 20,793,000 on expenses. So the costs are coming in pretty close to what we had budgeted. I wanted to then jump over several pages up to the other major financial piece of activity that occurred earlier in February. We made all these investments, and the rates of return just a little bit below 5%, and some of them are actually over 5% of $9.5 million that was invested in our new UBS consultants that are helping us on our investment portfolio. That alone translates just each month $38,000 a month. we're now in a position with all the money that's come in the last month or so on IGTs and in the ERC payment to invest another $8 million. So that totals close to 18 million. And if it's averaging 5%, most of you could do the math. 18 times 5, that's 900,000 a year in interest income. That compares favorably to what we finished last year at about 230,000 in interest income. So that's almost like $750,000 more in return because of the improvement in interest rates. So we're real pleased to have the right opportunities at the right time. Even though there's been delays in the construction project, we're at least taking advantage of our current liquidity to try to get as much to the bottom line as we can with these new investments.
Dave, this is Ross. I have a question for you on the treasury bonds.
Sure.
So if the US defaults on its debt, there's this fight between the White House and Congress over approving the debt limit. What does that do to the value of our treasury bonds? Are we going to lose?
There's never any risk on a treasury note unless the country defaulted completely, and I think we'd have worse problems than whether or not we get this money back. If the whole country, because keep in mind, these treasury notes are purchased by anybody in the world. They're relying on the credit worthiness of the United States of America. And the only reason we wouldn't get our money is if all of a sudden the country was in default.
Okay.
And I think there's a lot more other countries that will go in default before we do.
Yeah.
So it's really
Pretty scary though.
I think we'd have bigger problems than worrying about whether or not this money was safe. The one thing I do want to point out, these interest rates, they're the same every month. It's not subject to how the market goes. We're locked in at these rates every month until they mature in the various dates that they mature, that's listed on this column here. So that's another benefit to what we have here. We're not dealing with variable rate returns. We've got a fixed return that's real high. So anyway, we're real pleased with the combination of what happened with the ERC today and the ongoing benefit we're having with these investments.
Thanks, Dave.
Now I have one more issue that I'd like to discuss with the board. And if you go way back down to page 40 in the packet.
40 what, Dave?
35. It's the budget calendar. And I don't know if there's anything, I just kind of want to ask a question.
Dave, we can't hear you.
Page 45 in the packet.
You're way past 45.
Am I?
Yes, you are. You're on 60.
Oh, okay, thank you. It's the calendar for the budget. Because with Barbara and I being behind, one of the recent thoughts I had, if the board was open to it, and I don't know if you've ever done this before, but we've got a finance meeting on the last Wednesday in June. I think this should have been the 26th, not the 28th. Would the board consider holding a special board meeting so that we have the budget approved before the end of the fiscal year on the Thursday, the day after this finance meeting, on Thursday, the 27th, I believe it is the correct date, to have the board approval for that meeting, have the only agenda item for that meeting be the budget.
Could we change the building and planning to that date and do them both?
This would be a full board meeting. Yeah, I suppose because building and planning has all 5 board members too.
Right.
That might work. Because that buys Barbara and I 3 weeks, so we don't have to present it on June 5th. So anyway, it's just a thought, and I don't know if this is the right time to discuss that.
I personally don't have any issues, but what's the rest of the board?
We could have a special one, I'll move it.
Yeah.
And Heidi, you could probably arrange that better and let us know, right?
We needed to have one, we could.
Yeah, we can combine it with the building plan and grade if that works out, but if not, yeah, I'm certainly open to it.
Okay, I'm open to John, you fine. Miss Catherine?
Yeah, I'm fine with that.
Yeah, I don't see that being an issue, Dave.
That would be a big help. I appreciate it. I'll ask Tim if there's any other things we need to consider.
Okay, yeah, just keep us in the loop so we know what we need to do to help you.
Great, appreciate that. So is there any other questions or comments? I kind of made this report a little bit different because of the significant news that's outside of what happened in the month of February is probably more important.
Dave, I have a question, back on the, UBS and the treasuries. The ones that are coming due for maturity, did we already make plans or we're just gonna
Good question.
Because we have
In
one.
most
due in May.
cases, the way it's designed, there's only there's a small amount that's going to be maturing in the next few months. The way I put it in my model is we're going to need that money because that's a time period early next fiscal year where normally there's no IGT money comes in. So I did not plan on reinvesting any of our money, but it's going to be on a as needed basis. So when we get to that point, we'll always have the opportunity to reinvest it, which there is a fee to that every time we reinvest. So we want to minimize the reinvestment. If we don't need, the way I put together the model is when it matures is we'll have to use that money and give it to Bob to spend on the master project. So I don't really have too many gaps in my cash flow that once the money comes back in and the money's matured, we will withdraw it from UBS and pay vendors as it relates to our construction project.
Okay, because we have one in May. And then we have two in August. So you're planning.
23. Is that the right year?
Says. Date of maturity.
Yep.
5/18/23.
Yep, that's what it is.
Date of maturity 8/17/23 and 8/31/23.
You know, I wonder if that's a typo.
Well, I'm wondering what we're gonna do.
How many months does it say in the month column on that? I don't have.
3 months,
So
6
those are
months,
all-
7 months.
So those are all 3 months maturities?
Not all
No,
of them.
3, 6, 7, and 10. Yeah.
Oh, okay. And what's the total dollars there?
Okay, and this is your report.
4.35.
I wasn't prepared for that question. I
I'm
apologize.
sorry. You know,
It's 4.35, Dave.
Yeah, so out of, so we wanted to make sure, because a lot of times we'll go 6 months without any IGTs at that time of the fiscal year. We wanted to make sure that we didn't have to reinvest it. But it could very well be the situation because we're doing so well on cash, we may be reinvesting it, which might not be all bad, because keep in mind, the ones with the shorter maturities do have a higher interest rate. That you can see the ones that have a 3 month maturity is a little higher rate. So we are benefiting a little bit with that higher rate of return compared to a 2-year treasury. Can you see how the difference is on the interest rate?
Yes.
So that helps pay for a little bit of the fees that we pay every time we reinvest. So it's a trade-off. What I had to do is make sure I didn't put Barbara in a lurch where we needed the money to pay our normal bills and it was all invested. So I was a little bit careful this time to have maybe a little bit more than necessary mature before it was needed. So there might have to be some reinvestments going on, but in general, the way I set up my model is shouldn't be a lot of reinvesting when we have to, when it matures, I've got it identified as needed for payment on construction projects.
Okay, so what is your plan for the one that's maturing in May?
I'm gonna wait and see. And I'll have a discussion with Barbara based on whatever the cash position is at that point, whether she thinks she needs it. But you're right, we may be able to reinvest some of that money again back into the system because it has such a nice rate of return. We want to take advantage of that.
Okay, thank you.
There is an additional 3 million that you don't see on any of my reports, and that's money that when we did the financing back in 21, there was like 5 million that was available for construction. We spent a little bit of that, but there's still about 3.5 million in that particular account. That's in a money market earning about 3% interest. So besides, the 18 million or so at the 5%, we have another 3.5 million earning 3%. So the combined amounts get.
That's not on any of the reports?
No, but I can certainly put it all together in one piece for you so you can see it.
I would appreciate that.
And then I'll try to remember to also give you the summary of all the supplemental at the beginning of my presentation.
Perfect.
And Heidi will remind me.
Okay, Heidi.
I'll try.
Any other questions or comments?
Mr. Parks,
No,
question?
These are all moving pieces and if we didn't do anything at all, I wouldn't have anything to report, but we're making changes and they're all turning out good.
John?
Yeah, kind of to piggyback off what Ross was talking about earlier with the debt. I mean, this isn't interrelated to that, but does Gary Hicks maybe have any opinion about, I know there's some concern about the petrodollar not being used. Is this going to impact us by any chance? Does he have any input on that from a long-term trend standpoint, or
the value of the dollar?
Basically, yeah, because is this correct? The treasury bills, is that like T-bills or
T-bills? Yep.
Okay.
As far as Gary Hicks is concerned, like pretty much all professional investors, they'll all tell you that you can't get much safer than buying treasury bills. So it's even safer than a bank CD, even though the bank CD is insured by FDIC. Well, it's even better insurance to have because all the federal government has to do is just print more money. If they can't pay the interest off of a treasury bill, they, so, whether the value of that dollar stays as high is a good reason to have your money invested in other things other than cash, to have your dollars invested in other assets.
Yeah. I just look at things that are going on from a long-term standpoint, outside the US. There's a lot of alarming things going on, but
yeah, I certainly wouldn't want to have our money in equities. Yeah, I think stock market.
I agree. I'm not disagreeing with you there, but I think it's just stuff to kind of keep an eye out on. And
yeah, and we're going to be careful to make sure that none of our investments gets onto the risky side at all. And I have not found any consultants that have ever cautioned me against buying treasury bills. Any other questions or comments?
That's all I would.
No, that's it, Dave. Thank you.
Thank you.
All right, moving on. Show no old business. Under new business, item 1, resolution 2306. It's a resolution of the Board of Directors, Kern Valley Healthcare District, regarding the time and date change for the regular meetings. That's on pages 66 and 67. That's what we're discussing, moving our meetings to the second Thursday of each month at 3 p.m. like we're doing today. I personally think it works out great. How about the rest of the team?
Worked out well for me.
So far, yeah.
Okay, Ms. Rowland?
Personally, if I were the king of the world, I'd make it 2 o'clock instead of 3 o'clock. And I don't know if that Gives anybody any heartburn?
Two still works for me too, so.
Works for me.
I don't have issues either way.
If I had a choice, it would be after 5 o'clock where the public could be better for the public. Most people work
I agree,
and
as we do.
unavailable. So if I had a choice, it would be after 5. Other than that, it doesn't make any difference.
I believe when you had initially discussed 2 p.m., there was some concern that you guys may not be done with Exchange Club at 2 o'clock.
We would be.
Okay,
When did you discuss that?
you discussed it at the
All
last
of us
board
did at the
meeting?
last meeting.
Yeah, the last
Everybody did?
meeting.
Well, we discussed it, we didn't make any decisions.
That's how we
That's why
set
we're here
today's meeting.
today. Sorry.
Okay. Okay.
I think 2 o'clock is fine. It's not a day that I work this particular day of the week in the month. And I have been paying attention to the videos, and they're not watched until like the next day. Been looking at the views and stuff, and it's usually they don't watch them the same day. They're like watching them the next day or so,
There's a lot more watching than you know.
but it shows the
It shows
views.
the number of views.
Yeah, it shows,
Well, I don't know if somebody else is giving somebody else's views or what, but
I'm just referring to, if you go onto our website, you'll see the number.
yeah, that's what I'm referring to. And so I don't know that any of the time change or date change for us is gonna make a difference. They watch it after the fact. You know, after they're home from work or after dinner or.
Do you know if there are any comments on?
There's no comments, other unless, if Jim reposts it
Yeah.
and makes a comment, then there's a
A
couple,
little bit of chatter.
yeah,
Yeah,
but
But
not,
nobody's complaining about the times or anything.
no.
when you're gonna see it is whenever, like, let's say we go to put another proposition for the
Well,
more money, then you're gonna see some activity.
Sure.
yeah,
And so we might have to change it to 5 o'clock then.
or just, yeah, make it for a special one like we have now.
Right. Then, yeah, but other than that,
Okay,
should work.
I have no issues if we wish to change it from a 2 to a 3. Heidi, does that, you believe that works for the rest of your team?
The only one that might be a concern is Dr. Finstead. Thursdays, he said, are a bit problematic for him.
Do we need to check with him before making the change?
He can,
That's why I'm asking now.
we'll try to get a hold of him. I don't know.
Well, I know he's busy.
well, and Mark doesn't mind. Reading.
I prefer 3 because I go home at 3, but that's okay.
Yeah.
Whatever it takes.
Let's see, I guess we carry it over to see if it works for Dr. Finstead or.
We make a motion when we do it at 3, except if it doesn't work, or 2 rather. If it doesn't work for Dr.
Dr.
Finstead,
Finstead.
then we'll go ahead and make it
Okay,
2, 3, only temporary.
okay, so we'll move it to 2 o'clock. All right,
Second Thursday of the month.
yep. Okay, Jean made the motion, second.
Oh, second.
All right, Mr. Elliott, we're all in favor?
I,
Aye,
And
Okay.
and it's subject to change. We can do it every month.
we can,
So-
absolutely.
So Dr. Finstead, if it really,
Yeah, because we want to make sure the team's available.
he did a pretty good job.
He did.
Yeah. You're looking good. Mark.
but, and Dr. Finstead can always zoom in, correct?
Absolutely.
Okay,
Okay, second item, Greenberg Design Proposal for Professional Design Services. Central Crossing Hand Wash Fixture, pages 68 through 73 in the streets today.
So what that is when the CDK surveyors were here the first time,
Yes,
in going through the surgery area, they noticed that in our decontam, where we start the decontamination process of scopes and surgical equipment, that there was not a hand washing fixture. There never was one. When the building was designed, it wasn't required by code. But that has now changed. And of course, infection control is a very touchy subject. So I did look it up in code, and it is now currently required in code. It has been since 2016. So what this is to draw some plans to submit to HCI for the permit to open up the wall and bring the plumbing down and mount a sink for what is called a hand washing fixture. A hand washing fixture has to be hands free. You don't turn any knobs or anything. It's It's simply automatic. You put your hands in, wash your hands and shut off automatically. So there's a fair amount of work involved in doing it. But we did find a space where we could fit it in decontam. And so this is the cost to draw the plan for HVAC.
That's the 17.8.
Yes.
Okay.
Now, we're proposing to do our work. The actual physical work is not that extensive. So I'm hoping, as we get down to that point, that we can just do the work in-house. And so it won't cost a whole lot as far as the work. The big cost is the plans.
Can I make a motion to accept that as presented by?
I can't have one question before we get there. Sorry. Master plan, master project, is this throw a hiccup in the?
No, because the master project is covering the acute care.
All right,
This is in the surgical building.
all right.
Yeah.
Thank you. Sorry.
No, it wasn't. No, because we have no scope of work in surgery, dietary, or skilled nursing in the master project.
All right.
The newer buildings. There will be, just so everybody understands, down the road, there is some NPC requirements to NPC 4. We're currently NPC 2 on the newer buildings. And so there will be some cost proposals put together and whatnot, but that will be nearing at the end of the master project.
Okay.
I just make the motion where you're still gonna have discussion,
Yes.
but at least I try to
Start
move it.
from, understand.
Okay.
Gene made a motion, and second. All in favor?
Aye.
Aye.
Thank you, sir. All right, number 3, Greenberg Design again, proposal for professional design laundry door replacement.
Okay, so again, at the CDPH first inspection, there's in the hallway that goes there by the elevator down the staff hallway that goes down, we call it the laundry area on the left side. Originally, that area was designed to be a full-blown laundry. It was going to have large commercial machines, and we were going to do all the blankets and sheets and everything in the original design. That never got built. And so that big space is now divided into our, a training room and then what we call a linen exchange cart area. And then we have a small little laundry where we just launder the residents' clothes. So why they designed it as pairs of doors. The first pair of doors goes into where our laundry facility is. And then the second pair were not even designed for people to go through. They literally were to open so that service could be done on this massive piece of equipment that was going to sit on the other side of the wall. And so they don't close and latch properly. So and we've just used it, but we roll the linens in and out of that, the big carts, they're big carts. And we roll them out of these double doors. Well, they won't close and latch on their own, which is required by code. And when you let go of the doors, they're supposed to close, latch, etc. And the one set is so beat up and worn out. I've been working on them for several weeks and I still haven't got them to close and latch properly. The other pair can't close and latch properly against the air pressure of that space because it's a positive pressure room. So this proposal is to draw the plans to remove the 2 pairs of doors and install one single 4-foot door that has proper swing and closing that will close and latch and meet the requirements for life safety.
4 feet big enough.
Yes, yeah, oh yeah, because our carts are about 34 inches wide and we're going to put in a 4-foot door. So, yeah.
I'll make a motion, we accept it.
Second.
John?
Oh, go ahead.
And we are going to
You got it.
It's a minor amount of framing and then set the doors and frames and I've done those for many years. So we're going to do that.
The space he's talking about is the space where Kay Simpkins first started
Yes.
teaching the CNA program.
Yeah.
Yeah, the doors going into where the CNA classroom is, we're not changing those. Those still work and operate and close and latch. It's the next 2
Okay.
Yeah.
All in favor?
Aye.
Aye. Thank you. All right, number 4. This one's for you, Mr. Perks.
Okay,
Editing policy on Zoom.
do we have that in writing? We made a policy about how we do it and when we do it and everything, and I couldn't find it anywhere.
you like me to send? We do
Pardon
have a
me?
policy.
Pardon me,
We do have a policy I can send.
can you send it to me? What it is, and well, I wish you would have sent it to me for this meeting so I could, because we might
You did
want to
ask.
change it. Well, okay,
You want
And
to
that's
send
all.
it to you and then we can discuss it at the next.
then at the next board meeting, it's not anything that makes any difference right away, so it can drag out. If there's something that needs to be changed or clarified in it.
Yeah.
And the board should know about it anyway.
Sure.
And
Is there a specific question? Because now I'm gonna go back and read it.
okay, the editing, now originally, and Scott's here. It was just, it started out with a comment I made and it got chopped off, which is not the end of the world, because some of the things I say probably could be chopped off and wouldn't make any difference. But it was not so much editing and changing stuff as eliminating it. And so, right, Scott, is that what you told me?
So what you guys do and what Gene is referring to is the recording was on before the meeting started. And so when the video was posted, the pre-meeting discussion was not included because it's not really relevant to the items on the agenda or the decisions the board is making. So the video was just from when the meeting was called to order until when it was adjourned. I don't know if Gene wants the whole thing to be posted or what he's asking for, but that is how you currently do it. You only post a recording of the actual meeting itself.
Okay, so at that one point back when, we agreed that if two board members felt like it was something that was said at the board meeting that they felt like shouldn't be on there, they could actually take it off of the tape.
No, that
No.
had been proposed,
Okay.
but it wasn't ever approved.
Okay, so no, that's my question.
Yeah.
What is the policy? What is it?
We'll send you a copy of the policy just after.
Okay, so then we can't do it. Okay.
Yeah.
Not from the minute you
Yeah,
say
from
the
the
meeting is called to order until.
They
the
can't-
meeting
So
goes
if
to
we
the-
accidentally record pre-meeting, then.
Right.
Yeah,
And
take it off.
Heidi's been really good about like, okay, I'm starting the recording,
Exactly.
so.
That's
Okay,
why
good.
I
I just
tried
wanted
that.
to
Yeah.
make sure I knew when I go back to read it.
Yes.
Thank
Okay.
you.
Thank you, Jinx. I want to read it as well to make sure we're on the same page.
Yeah, and then just so we.
But
Okay.
what about issues like, I mean, because you brought it up during the meeting, like a potential HIPAA violation, how do we address, like if those things were to come up?
Yeah.
Yeah,
I mean,
Yeah,
what
that's
do you,
good.
what do you do about that?
Yeah.
Like, Scott, do you have any input on kind of?
Yeah, so what I would say is if that situation arose, I would not delete anything. I would just and Carrie would have to describe, I think, how you would do this, but you would just edit the sound. So you would take away the audio for whatever, say, that HIPAA violation was.
Okay.
Right, but we wouldn't cut the video and remove that portion of the video. Right, and then if we wanted to be clear with the public, we would just put an explanation with it and say audio was whatever the technical term is for this time frame for legal reasons, something like that.
Redacted or something.
yeah, that makes sense.
We just need to know the policy. I don't.
Yeah.
Just-
Right. Yeah, definitely, because I usually sprout off stuff I'm not. It's covering my own. Thanks, Gene. Got my
Thank you,
back.
Scott.
Well, we had the discussion about this, I think probably before you got on the board. Scott had advised us at the time, you better mind your manners because we can't edit it.
Yeah, well, and I guess being in, the medical field for a long time, I don't want to be scolded for something like that because I know, the importance of it.
Absolutely.
But sometimes we're chatting, and
Right.
like you had permission, but yeah, no, I didn't. I was like, you know, but I didn't want to call you out.
Right.
So I just, yeah, I'm glad that we're getting clarification on that because that makes, because we will slip.
We will.
That, you know, human
It's
nature.
happened
so.
before.
So I guess as long as all of you know, first of all, this is voluntary that you're doing it, and it's a great thing. I think it's important for the public. You're not required to do it, but you have decided to do it. So kudos to you for deciding to do that. However, what is posted is the meeting. Are you? And I mean, I suppose you can say we're going to post all pre-meeting comments and all post-meeting comments, but you're not legally required to do so. And I think the decision at the time was just to post the actual meeting portion of the video.
Makes sense.
But if we make an error, like HIPAA, like Catherine was saying, if we say something that shouldn't have been said, then we could.
Just take out
You
the,
can edit the sound.
And maybe put in writing why we took it out.
yeah.
We cross that bridge when we come to it.
Yeah, okay,
Perfect.
all right, but meanwhile, we'll have something in place to look at.
But one statement that Scott made, Gene, which I think is very important. If we're discussing something just pre-meeting that we determine is important, we can bring it to the next
Yeah,
meeting
right,
and
right.
introduce it at that time.
Oh, that's
Okay,
true.
all right,
Yeah.
that's all I just wanted clarification basically.
All right,
Thank you.
okay, thank you. Director's comments, Mr. Park?
Nope, I'm glad I made it through the whole meeting.
Me too. Mr. Charlie?
No, I don't have anything to add today. Thank you.
Ms. Catherine?
No, I don't have anything.
John?
Yeah, I got a couple of things. So.
Go.
So today Carrie's dad, Gary, had the veterans breakfast down at the VFW, and the VA came up from LA. And so I went there to just kind of
Nice.
represent the hospital, and they're still very excited about trying to move forward with the hospital. They had a panel that came up, and we're kind of trying to show the veterans about how telehealth works, those kind of things. But one of the concerns that they were kind of voicing to the VA is that we need a patient advocate here to kind of get a better understanding of what their services want. And then maybe we just keep moving this forward until we get to a point where we can somehow figure out how the district can partner with the VA, maybe a couple times a month or something like that. And then secondly, I know this might be a little controversial, but there's some push going on in the community about dealing with the homelessness. And I think, forgive me, your other clinic.
The other clinic is Clinic
Zero
Material,
Vista,
67 East Avenue, Wilford Heights.
That was a steakhouse.
But I know that they're trying to partner with some of the concerned citizens, shall we say, to deal with the homelessness issue and some of the mental health services. And I'm just wondering if maybe the hospital might be able to help out with that with our mobile unit. I know I'd say it's controversial because I know homeless is a really.
It's a touchy one.
It is.
That's
It is.
a very difficult egg to crack, and it's going to be very costly to start trying to crack that egg.
Yeah.
Very costly. I mean, their mental health, as a lot of you know, I don't know that there's any cure for a mental health condition. There's always treatment for it,
Right.
but it's not like an antibiotic will solve that problem. So it never does go away.
And they have to be the ones that want the help. Nobody can kind of
Agree.
lead a horse to water. You can't make it.
So I just don't, and being a patient advocate, I really, I kind of feel for them. And I really wish there was more being done at a higher level than what we can provide. If we could get grant funding for programs that could solve some of this stuff, I think that we would be, willing to do that. But I just don't know in the healthcare industry if people want to even work in the industry anymore. It just seems like, the behavioral health is very difficult. I was having this conversation this morning with some friends of mine, and man, homelessness goes hand in hand with drug addiction and behavioral health. I mean, it's a very, very difficult and it's a big, big problem.
Yeah.
One of the things I'd like to say is those that are homeless are the ones we see with the addictions or the mental health. But yet we could be sitting right next to somebody that has the same problems that are on meds
In their
and
function.
they're
Yep,
functioning.
absolutely.
And so, but as with those that are homeless and those that aren't, they take their medications and they're like, hey, I feel pretty good. I don't need it.
Right.
Then you have that cycle. Once you go through that cycle, it seems like sometimes it gets harder and harder each time because they go farther and farther down.
Right.
And so it is really a touchy one, not only because of that, but they have rights. And when you start trying to help, they see it as we're stepping on their rights, and government also sees it the
Right.
same way. So that is a very touchy one. I know college community works with a lot, and it's difficult, you know. I was talking to someone that, you know, employees have their Narcan, they have it, and they can, you know, people can come in and get, you know, up to 4 different ones.
Right.
And they'll come pick it up before they start doing the drugs. So the person there, whoever is the most alert, can use
Mhm.
that on them. Just watched it on a parking lot yesterday.
Yeah.
In Bakersfield. So it's like we're sending out so many mixed, you know, options.
The message is, it's okay.
It's okay.
And
Here, we'll help
or
you.
do
Yeah.
you want to be treated?
Yeah.
So the other thing is, I will say from a hospital perspective, Tim and I about 4 or 5 months ago, met with Stacy Kuahara, who took Bill Walker's place, and Tanya Mann, who's in charge of Mary Kay Shell.
Right.
And we met with those two and we discussed perhaps looking at an option to turn part of our skilled nursing facility into a mental health, a behavioral health kind of,
Right.
maybe 10 or 12 beds out of the ones that are there. That requires an incredible amount of work for a new nurses station. And it has to be separate from the skilled nursing center. It's a lot of work.
Wall off. part
And
of
they were excited about that prospect.
Okay.
I know that, and I'm sure there's probably grant money out there to get something like that going. Staffing that is another issue that it would be part of my concern. How are we going to staff it? So mental health professionals are, you know, they're few and far between. They're difficult to find. So these are really, really, really big problems. Love to help.
Yeah.
I'm not sure where we're at with it.
Okay.
Sometimes helping can hurt. It's a problem. It's a problem.
Yeah.
Yeah.
And it's their most of the time it's their choice. And you talk to them and they'll say, well, gee, all I gotta do when I wake up is worry about how to eat, get me a sandwich for, you know, lunch or whatever.
Right.
And they don't have no car bills, they don't have nothing. They're just there. That's what they would say to me.
A lot of them do.
Their choice.
But some of them say that because of the mental health.
Yeah.
So you have it on both ends.
Also the defense.
Oh, yeah. Yeah, it's a sad situation, but anything I think this facility could do for our community would be
Yeah.
huge.
So, John, as far as the VA, I was wanting to go this morning, but I had meetings all morning. I couldn't break away. I do want to participate in that. And I was in the first meeting.
Yeah.
I would like for them to be able to meet here so we can talk about some real things at that venue at the VFW. It's great to have breakfast, but you can't really talk about business.
Yeah, I was telling that to Gary too, because also the acoustics in the VFW, it gets really loud. You got conversations going on over here. It carries into the room where they're trying to have the meeting, and they actually had it set up like this with a flat screen TV, and they were trying to get connection. It just didn't work. I'm like, maybe we could try to move that aspect of it to here or somewhere where it's more you know,
Conductive.
yeah.
It really,
They change so much. VA,
The VA, yeah.
with different administration, they treat stuff different, it's forever changing. Now, I'm not being negative about efforts.
Yeah, well, actually, they mentioned that today. It's like, it seems everything's changing like every other
Yeah.
year, or every other month for that matter.
being a veteran myself, I think it's important to be able to provide that service as much as we can.
Yeah, instead of having them go to the west.
I have dealt with, anyway,
Yeah.
that's another day, another story for another day.
And the only other thing I wanted to say, I've been, Catherine, you've been in my thoughts and prayers,
Mhm.
and I didn't want to upset you before the meeting started, but my brother recently got into a really bad accident in the canyon too. He is okay, but the SUV wasn't, and so it really hit kind of close to home too, so.
It's been tough.
Yeah.
So, and yeah, I'm sorry for your brother too. That's, but he's okay.
He's okay.
Yeah.
But it could have been worse. Yeah.
Yeah.
So
Thank you.
my thoughts and prayers have been with you and your family.
Thank you.
Now, that was Joy.
That was Joy. That was, last week. That's all they had.
I just wanted to say thank you for everyone for being here. Sorry that Tim wasn't here. He gets better soon. Ms. Heidi,
Glad I could
thank
be
you for
able to,
keeping it on the straight and narrow as you always do.
Fill in.
We appreciate it.
Yeah.
You
Yeah.
write those things very nice.
Yeah.
Let's move on to closed session.
Sorry.
Scott, it's all you, sir.
Thank you. In closed session, the board heard the medical quality report. No action was taken and no other items were discussed.
Thank you, everybody. It's 4:58. We're adjourned except for Mr. Park. He said you wanted to stay till 6. So stand over there and hold the door for us. Have a good evening, everybody. Stay safe.
Thanks, everyone.
Good night.